Yes. Yes. ठीक है. Good afternoon, everyone, and thanks a lot for giving me a chance to speak on this prestigious dais. So, as a second-year medical resident of Santosh Medical College, I will be presenting a case of a young female who presented to us with complaints of pain abdomen, fever, and ascites. So, to start with, the patient is a 20-year-old female resident of Ghaziabad, Siddharth Vihar, and had an IPD stay at a hospital on two different occasions. First one was in September, and the second one was in October. To start with, the patient presented to us with complaints of abdominal distension. This is the cumulative time period I'm telling you from since the first appearance of the symptoms till date. So the abdominal distension, the patient was having abdominal distension since past 3 months, abdominal pain since 3 months, nausea and vomiting since 2 months, and fever since 3 months. So to move on for a history of presenting illness, the patient was apparently all right previously, but since August, mid-August, patient started experiencing pain abdomen, which was gradual in onset, was most likely localized in the epigastric region, was pricking in nature, persistent, but was non-radiating. The severity was from moderate to severe, that the patient even required intermittent use of analgesics to relieve the pain. The course was gradually progressive. Over 30 days, the pain was gradually increasing up, and there were no relieving factors as such. Associated symptoms were nausea since onset and vomiting 1 to 2 episodes per day, which were non-bilous, non-projectile, abdominal distension, and with no history of any diarrhea, constipation, or hematemesis or melena. So patient had abdominal distension since August, which was insidious and began as a mild abdominal fullness. It gradually progressed over weeks, and it was steady. There was a steady increase in abdominal girth. As per the patient, the clothes started becoming tighter. There was persistent distension of abdomen throughout the day, and the patient usually described this sensation as sense of heaviness, tightness, and diffuse fullness. The distension was generalized abdominal. There was a generalized abdominal enlargement. The pain was localized in the upper abdominal region and lower abdominal region at times. Associated GI symptoms were nausea, occasional non-projectile vomiting, and but the patient had normal bowel movements with no constipation, and there were no cramping or diarrhea. The patient had no urinary symptoms, and there was no any history of pedal edema, jaundice, melena, hematemesis, or any menstrual irregularities. So the patient also developed fever around the same time. The patient had been experiencing fever since August, which was approximately 1 month prior to the presentation in the OPD. The fever was intermittent, predominantly evening rise of temperature, was associated with chills. There were no rigors. It was accompanied by a headache, which was usually during febrile spikes, and it was not associated with photophobia, neck stiffness, vomiting, altered sensorium, or any seizure-like activity. The fever ranged from 100 to 101 degree Fahrenheit. Patient had vomiting, which was non-bilious, non-projectile, contained food particles. There were 1 to 2 episodes per day during symptomatic periods. It was preceded by persistent nausea, episodic worsens with large meals, and there was partial relief after vomiting. There was associated symptoms include progressive abdominal distension and fullness in September, intermittent fever with chills, loss of appetite, early satiety, no hematemesis, no melena, no bilious vomiting, and no constipation or obstipation. For the personal history, patient is used to consume balanced diet, is a vegetarian, and has decreased appetite since the onset of the illness. The patient is is a graduate student of BSc, belongs to upper middle class family, has no pets or no history of any recent travels. Patient is non-alcoholic, does not smoke, and does not do any kind of recreational drugs. Bowel and bladder habits were normal, and there were no comorbidities. The menstrual history includes the age of menarche at 12 years. Initial pattern was regular. Cycle lasts for 28 days. Duration of flow is around 5 days. Frequency is regular with the normal flow of blood. And she changes around 3 pads per day with no presence of clots or flooding episodes. Last menstrual period was on 22nd of September 25. The patient does have dysmenorrhea. The pain is spasmodic, which is mild to moderate and occurs during the cycle and relieved by analgesics and rest. The family history includes it's a non-consanguineous marriage between the parents. The family includes 6 members, 3 daughters, 1 son, and 2 parents. There is a family history of tuberculosis, as the father had diagnosed pulmonary cox in 2002 and had completed ETT in the same year for 6 months. There is no family history of any genetic disorders, congenital abnormalities, or any developmental delay. There is no family history of hypertension, DM, CAD, stroke, CKD, or CLD. And there is no history of any malignancy in the family. To begin with, the past history of the patient includes that the patient at the age of 12 years was diagnosed with pulmonary cox, the records which were not available with them. As per the parent, the patient had taken ATT for 4 months and then had stopped. So the next admission was, so then the patient in year 2023 in the month of October got admitted at Santosh Medical College with the history of a month-long fever, which was low-grade progressive, associated with abdominal distension, nausea, and generalized weakness. The patient was evaluated this time. At that time, the patient, on the basis of ascitic fluid and pleural fluid, was diagnosed to have an disseminated cox of pulmonary and abdominal origin. The patient was started on ATT, the regular 4 drugs, and had completed her duration of ATT for 12 months. Now, the patient was apparently fine after this, but in month of May, the patient had started developing some kind of upper abdominal discomfort and pain. The patient followed up in the gastro OPD, where she underwent a UGI endoscopy and was diagnosed to have a H. pylori associated gastritis, for which she completed her H. pylori kit for 21 days. At time of presentation, the patient had a BP of 160 mm Hg, which was checked in the sitting position over the right arm. The pulse rate was around 110 per minute with regular normovolumic. All peripheral pulses were present. Respiratory rate was around 20 per minute. Temperature of 102.9 degree Fahrenheit. Saturation was normal at 98% on room air, and RBS was of 100 milligram per deciliter. Patient had no pallor. The patient had pallor in bilateral lower conjunctiva. There was no icterus, no cyanosis, no clubbing, no lymphadenopathy or edema at time of admission. The height of the patient is 168 centimeters with a weight of 65 kg and a normal BMI of 23 kg meter square. This is upon examination, the central nervous system examination was grossly normal. There was no higher motor function. All the higher motor functions were intact. Patient was conscious, oriented, time, place person, and was following commands. The pupils were bilaterally reactive of 3 mm. Planters were bilateral flexor. Power was 5/5 in 4 limbs. There were no meningeal signs or other focal neurological deficits. The cardiovascular system was also relatively normal on examination. On inspection, there was no bulge, scars, deformities, no visible pulsations. The apex beat was felt on the 4th to 5th intercostal space in the mid-clavicular line. All peripheral pulses were palpable in all 4 limbs, and on auscultation, S1 and S2 were heard, and there was no murmur. Respiratory system also was normal on examination. Upon examining the GI system, the shape of the abdomen was distended but symmetrical. The umbilicus was centrally located, mildly everted. The skin showed no visible veins, no scars, no striae, no rashes, and there were no cutaneous nodules. Visible paracelsus was not observed, and there were no hernial visible groin or umbilical hernias. Upon palpation, there was no local rise of temperature. Though there was mild diffuse abdominal discomfort due to distension, and there was localized guarding, no rebound tenderness. Rigidity was absent. There was no splenomegaly. There was no hepatomegaly, and there were no masses palpable. The patient on percussion had shifting dullness, but the fluid thrill was absent. On auscultation, the bowel sounds were present and no bruit were heard. So to begin with, we'll be starting with the first admission of the patient, that is in this month of September 2025.
Dr. Ankit, require salient features in history and examination.
Sir,
Short.
Ji, sir. So we have a 20-year-old female patient, sir, with a past history of abdominal cocks, for which she took ATT for abdominal plus EPTV, sir, pleural and abdominal cocks, for which she took ATT for 12 months from the month of October of 23 to 24 October, October of 24th. So the patient, sir, presented to us with the complaints of
Abdominal
cocks.
What kind of abdominal?
So patient had ascites at that time. So at the time, in 2023, she had ascites as well as she had pleural effusion, sir. So both of them were aspirated. Diagnostic aspiration was done and was evaluated and was found to be of tubercular origin, sir. At the time in 2023, sir.
And you said disseminated.
Yes, sir.
So disseminated means more than two
or
systems.
systems. Yes, sir. So now the patient, being almost okay for a year, she again presented to us with similar complaints, sir. The patient was having fever since 1 month prior to first OPD consultation, which was low to moderate grade, sir, with evening rise of temperature. Patient also had pain abdomen, sir, with a mild to moderate severity, localized usually mostly in the upper epigastric region, and sometimes in the lower abdomen. The patient also complained of abdominal distension, in the sense that the patient was feeling discomfort, heaviness in the abdomen, and her clothes were gradually becoming tighter, sir. The patient also had patient was experiencing nausea and vomiting on daily basis, having 1 or 2 episodes of vomiting, sir, after consumption of meals. And the vomitus was non-bilious, and it usually included all the gastric contents or the food materials which she had consumed earlier. The patient, sir, on examination, she was having mild pallor, sir, on lower palpable conjunctiva, but rest other findings were not significant, sir. The patient had normal BMI for her age. Upon systemic examination of the patient, sir, we found to have abdominal. The patient was having abdominal distension. There was no organomegaly at palpation, and fluid thrill was present, sir. The patient was shifted on one side, and the flanks got full, and which was percussed to get the dull note. And sir, as of now, this is the history of the patient.
What do you think?
What is the working diagnosis?
So at this point of the time, the working diagnosis could be the patient is again having reactivation of the cocks at the present, because the symptoms, the progression of fever, all correlate with the pathogenesis of cocks.
Your comments on that, because patient is already taken for 1 year and again the patient is symptom. How will you see the difference from very uncommon?
Ascites is a possible specific tuberculosis resistance, very uncommon things in there. So if the patient not had any evidence of pulmonary tuberculosis or multiple tuberculosis, this is likely to be slightly uncommon in my clinical practice.
But I'll tell you what wrong is with. So this case, this young female, basically she had a very strong prior history of tuberculosis, and then she had a history of pulmonary cocks in her childhood. Then she again had a recent history of tuberculosis, disseminated cocks. Plus the father also had a history of pulmonary cocks.
Sorry, she had tuberculosis twice.
Yes.
12 years, and
Then at this in 2023.
At that time, considered a very strong personal and a family history. At that time, we hadn't kept the suspicion of tuberculosis. There's a reactivation of tuberculosis at that point, and we had investigated her accordingly, keeping other possibilities as well.
At that time, there was only ascites and pleural. There was nothing else.
In 2020.
So in 2023.
What were the other possibilities? The time of
So apart from that, other possibilities that we could have considered could be any other chronic illness, could be a benign tumors of the abdomen. That could be a possibility. And yes, so for the
Benign
Yeah.
tumors leading to
like you can ovarian fibromas or something like that. But again, those are very rare. So, but at the onset, at the first onset, we had kept the possibility of POX only.
So at present, I think it looks like that she has reacted.
Yes.
Okay.
Right.
So on the first admission, that was in September, the patient was admitted with fever, abdominal pain, abdominal distension, and vomiting. Vitals were stable, mild pallor noted. Initial evaluation suggested moderate ascites and abdominal tenderness. In early hospital investigations, the baseline infectious workup was basically negative, and the laboratory findings concluded mild anemia, neutrophilic leukocytosis, LFTs mildly elevated transaminases at baseline. KFT was within normal limits. The urine and blood cultures were sterile. USG whole abdomen was done for the patient, which was suggestive of mild to moderate septated ascites with omental thickening with a query of tubercular etiology. There was a right renal calculus of 2.4 mm. The abdomen was gaseous and patient was advised for ascitic fluid analysis and CCT whole abdomen. So we undertook the patient for USG guided ascitic fluid analysis, and these were the findings. The total count of the ascitic fluid was 1800 cells, which was lymphocytic predominant of 97%. It was low seg and high protein, and ADA was 48.9. AFB stain was negative. Gram stain had pus cells but showed no organisms. Cultures were sterile, and CB net was negative for the patient. Then again, after getting the reports, we got a patient CT whole abdomen done, which was suggestive of moderate ascites with omental standing and thickening with the bilateral hydrosalpinx with enhancing walls suggestive of salpingitis. And the features were suggestive of tubercular etiology, ascitic, and again, they were advised for ascitic fluid analysis. So, given the history of disseminated TB, ascites, omental thickening, it was suggestive of, at that point of time, it was suggestive of reactivation of abdominal COX. And therefore, patient was started on empirical ATT on 8 of September 2025 for abdominal TB reactivation. Now, the patient, Hanji sir, gene expert was done, sir. CB net was negative at that time. So the patient the patient was with us for another 4 to 5 days where we were observing the patient. The patient's febrile episodes gradually started going down. So and the patient stayed afebrile for 3 days prior to the discharge, sir. So this was the X-ray at the time of presentation in September. So this is an X-ray in PA view of PA view, and sir, PA sir, posterior and anterior view, sir. And the patient over here, sir, the heart size appears to be normal. There, the Costophrenetic angles are visible. Then there's no visible blunting. No, sir, grossly appears to be normal, sir, with some hilar markings.
Essentially normal.
Normal X-ray. Sir, upon admission, then the patient again visited to us in the month of October, and during this time she was visiting to us in the OPD on regular basis. So now the patient, when presented on 10th of October, the patient again started complaining of abdominal distension. Patient started having high-grade fever since last 7 to 10 days. The pain abdomen increased since last 10 days, and the nausea was persisting for last 10 days. At admission, the past history was again reviewed, and the patient considering the symptoms plus ascites, again we went for the evaluation of TB peritonitis, genitourinary tuberculosis. There was suspicion of ATT-induced gastritis or hepatitis or DILI. The LFT done at our hospital showed transaminitis with SGOT of 184 and PT of 130. And the rising liver enzymes in the further titers made us suspect of DILI. Initial blood investigation showed microcytic hypochromic anemia with neutrophilia. KFT was normal, CRP was 33.47, infectious workup was negative, urine and blood cultures were negative, were sterile. So,
What was the
sir, HRZD, patient was taking HRZD 4 tablets.
In LFT, SGOT was 198, SGPT 123.
जी sir.
So you started it on this also?
No sir. The previous, this is the second admission sir. ये ATT लेते हुए उसको 15 दिन हो गए हैं sir. Sorry. Diagnosis of Daily was made and ATT was modified on 12th of October. There was worsening of SGOT and PTs, SGOT being 342 and SGPT being 193. And, जी sir, the drug-induced liver injury. So anti-tubercular drugs were modified and patient was started on liver support therapy and serial LFT monitoring. Gastro consultation was again taken and was advised for another USG guided ascitic tapping and to modify ATT. The ATT was modified and patient was started on ethambutol 1.2 gram and levoflox 750 per oral OD. For hepatic support, ursodeoxycholic acid was added at a 300 mg BD dose. Now, again, we did a USG whole abdomen the same day, and it was suggestive of a bulky spleen, cystic lesion with echos and hyperechoic membrane in the right adnexa, which was likely suggestive of a hemorrhagic ovarian cyst. There was left salpingitis and moderate ascites with echos, septations along with the omental thickening. The patient was again taken up for USG guided ascitic tapping. Now, the second ascitic tapping revealed the WBC counts of 250 cells, 2,550 cells, with again lymphocytic predominance of 90%. The cytic fluid was negative for any malignant cells. ADA was 66.9 and the cultures were negative. The cytic fluid was low SAG and high protein. So in the view of ultrasound findings, we took a OBGY consult and as per their advice, they advised for an MRI whole abdomen along with tumor markers in the view of the salpingitis which was seen. So the MRI findings were suggestive of a right ovarian hemorrhagic cyst with retracted clot, mildly dilated left fallopian tube suggestive of subacute chronic salpingitis. There was moderate ascites with omentomesenteric thickening, likely secondary to tubercular peritonitis in view of underlying abdominal COX. Now here as we can see the markers which was sent, CA 125 came out to be 158, which was elevated. CA 19.9, CE and alpha fetoprotein were negative. So now after the reports, there was a multidisciplinary meeting held in which OBGY, General Medicine, TB and Chest Department reviewed the case and tumor marker reports along with the MRI reports. The team advised that the patient must undergo a PET CT scan to further evaluate and to rule out any malignancy or any residual disease process. So now we got a patient FDG PET done on 17th of October, which revealed bilateral FDG avid multicystic adnexal lesions, gross ascites, diffuse FDG avid peritoneal omental thickening, bowel serosal involvement, and there was no distinct metastasis. The impression was suggestive of a carcinoma ovary with peritoneal carcinomatosis, but TB peritonitis remained a differential. Now, post this, the patient again a multidisciplinary committee was held, and and after the discussion, it was decided that the patient had to be continued on treatment for tuberculosis on the modified ATT, giving the options, keeping the option of CA ovary as an open option. For that, it was also decided that patient should undergo a tissue biopsy for the same, but upon telling the patient, sir, the parents refused to undergo the biopsy, sir. The patients were, the attendants were explained about this, and finally it was decided that we refer the patient to the higher center, sir. So this was the FDG report of the patient. So as you can see, there are irregular multicystic bilateral adnexal lesions with increased FDG uptake, and with, the size of right adnexal lesion was around 4.6 into 3.7 centimeters, and left was around 4.7 into 2.2. There is diffused omental thickening, mesenteric stranding, and bowel clumping. Ascites is massive with diffuse involvement, and the differential diagnosis of TB is also maintained in this report. So to summarize this, the initial evaluation revealed the patient and the baseline investigations were pointing towards tubercular ascites, tubercular etiology only. But after taking ATT, the patient had developed drug-induced liver injury for which the ATT had to be modified, and the patient underwent a review ascitic fluid analysis. So again, in that, we could make out that the ADA was on the increasing trends from 48 to 66, and the tumor and the MRI, which was done on the advice of OBGY in view of salpingitis, post which it was decided to send tumor markers in which CA125 came to be positive. Now, post this, we got a FDG PET done, which revealed that the patient might have CA ovaries, keeping the option of tuberculosis also open. So now, post this, the patient was discharged and referred to higher center on the 18th of October. Sir. So the final diagnosis of the patient remains as disseminated Cox abdomen plus genitourinary on modified ATT with ATT-induced hepatitis, bilateral ovarian cyst. We don't know about the nature of it, with salpingitis. So the differential diagnosis which were kept right now are disseminated Cox, CA ovaries, germ cell tumors, and even a multi-drug resistant tuberculosis. So this is the workup of the patient. This is the second X-ray which was done, which we can say is relatively normal. ECG, this is the CBC of the patient. Peripheral smear. The LFT, serial LFTs which were done. So we can see there was an increasing trend initially, and after on 12th, when we modified the ATT, the trend started going towards down. The KFTs were normal. Tumor markers, CA125 was 158, CA 19.9, 23.3, CA 0.72, AF alpha fetoprotein 0.77. MRI whole abdomen findings, I have discussed this earlier. And follow-up, now the patient was referred from our hospital. So the patient went to Delhi State Cancer Institute. And over there, the patient was again evaluated. Again, a USG whole abdomen was done, which revealed mild ascites, right adnexal mass of 4.5 into 3.4 centimeters with hypoquick lesions with multiple internal septae, which was likely a complex ovarian lesion. CA 125 was again done at the same center, which came out to be 266. CA 19.9 was 24. AFP, CA 72.4, CEA, beta HCG were normal. The patient, as per Delhi State Cancer Institute advice, was advised to undergo a USG guided tapping after ascitic tapping after 1 month with a monthly follow-up for weight and abdominal girth. Patient was advised to continue modified ATT as per the ROTS and was referred for gynae oncosurgery or oncology. So for that, the patient then visited AIIMS, OBGY, and the reports and all the investigations were reviewed over there. And the patient was advised to continue on modified ATT with DOTS follow-up and was advised again for a repeat USG and tumor markers after 3 months. The third institute, the patient went there by themselves. This was just like 3-4 days back. So again, over there, they have told the patient to measure CA125 again, continue modify ATT and evaluate for malignancy and follow up with them. Now, what is the gray zone in this case? The diagnosis, the dilemma remains whether it's TB, or it's the other way around. So to sum up everything in one line, so the issue is the tissue. So as the patient has not undergone any tissue biopsy, it's very difficult just to on the lab reports to make a confirmative diagnosis of whether it's tuberculosis or CA. But given the picture and the overall presentation of the patient, there's certain points which favor more towards tuberculosis, such as the patient being a young female, having a previous history of pulmonary EPTB in 2023, which again could be again a reactivation in 2025. There is a strong family history of the father being diagnosed with pulmonary COX in 2002. The patient ascitic fluid revealed low sag, high protein. The ascites was separated. ADA was on increasing trend 48.9 to 66.9, which in case of malignancy does not go up to such an extent. USG was also suggestive of mental thickening and separated ascites. And the cell blocks, the malignant cells were not found in both of the ascitic taps which were done in our institute. But keeping the diagnosis of CA ovaries also open, the certain pointers are the elevated CA125 levels, the FDG PET, which shows bilateral adnexal lesions, and CBNAT and AFB being negative in the patient ascitic fluid side.
That will do the fever and ascites. Actually, this is followed up everywhere.
So the fever, so the ascites has gone down, sir. So as you can see in the Delhi state, this thing when the review ultrasound was done, it's minimal ascites. The fever has subsided, sir. The fever, the right now the patient came on this Friday to our OPD when on follow up. So the patient had a one spike of evening rise of temperature on Thursday. That's all, sir. From discharge till now, there has been only one or two spikes of fever, and that is like ATT, yes, sir. And that is the reason, sir, they are giving so even the higher centers such as AIMS and Delhi Cancer Institute are given a time for 3 months, sir, because sir, as we can see, the patient is currently on modified ATT. So the full effect of the drug or the ATT will take much more time. The delay in the effect to come also is contributed by the liver injury which patient developed during the course of the treatment. So given 3 months, 12 weeks, 6 to 12 weeks of the time, and if the LFT stabilizes, we can gradually increase the ATT and introduce all the 4 drugs, and then we can wait for the appropriate response and can follow up for the patients. Keeping
Dr. Ankit, wonderful presentation. Let me give you a big cheers. But I have two queries. One, any further investigation like peritoneal biopsy? You have already taken the opinion of gastroenterologist.
Yes, sir.
So, peritoneal biopsy could have been done, number one. Number two, is there any role of steroid in such a circumstances? They are my two queries.
Yes, sir. The steroids do help in patients with the ascites, but it's not normally advised, sir. The scenario has to be ascertained, sir. Like most of the patients with ascites of with TB peritonitis, the ascites tends to start resolving when the ATD comes into its effect. But in some patients, it's necessary to resolve to use steroids to get down the ascites.
I think Dr. Bigu can give the final comment. Thank you, Dr. Very interesting. Good yeah, for it. I think Bigu, final comment because the pet issue is an issue that we have discussed in a lot of conferences that the issue near that we cannot make it as diagnosis. Regarding CA, I would say a certain marker is for the omnipotent cough function, non-positive. So CA can be on the high side, and after eating at 2 or 3 months, the CA will come down. One of my patient NABH employee and she had the same from box that is 18 high and good. Her CA is done, just done routine. The CA was high, and so very impressive was being NABH. Because after my diet, how the CA right, and she did all the tests for it. So I just made him that one was positive. And don't worry, after we'll go for after 6 to 8 weeks. After 6 to 8 weeks, the CA came down. So it's a normal thing, but we have a mask also. This mask cannot be ruled out. So I think tissue is one of the things that can be diagnosed. But definitely the patient is responding. I think we should continue.
What about peritoneal biopsy?
As we discussed,
We have asked for both biopsies.
नहीं अगर हाँ कह रहे हो तो करते क्या? डॉक्टर बिल्कुल बताएंगे.
So in this case where there has been she's been retreated after a year, and we started saying this is not common. This means we are either dealing with, we should have a differential of either MDR tuberculosis kind of thing or something else. So
MDR होता तो 1 साल तक asymptomatic क्यों रहता?
sir,
MDR तो नहीं होता.
sir, MDR is multi-drug resistant, but what is the maybe not MDR, maybe single drug. See, so
नहीं मेरा कहने का मतलब है सर रिस्पॉन्ड कर दिया 1 साल तक एसिम्प्टोमेटिक रहा
So लेकिन
MDR क्यों?
ना वापस आया ना system. 1 साल के अंदर वापस आ रहा है. तो इनिशियल रिस्पांस आएगा, बाद में वापस आ जाएगा. This is
रीएक्टिवेशन हुआ ना सर MDR क्यों हुआ? यही तो मैं कह रहा हूँ.
ऐसा होता है इन्हीं के बाद ट्रीट करते हैं
MDR नहीं हुआ सर 1 साल तक एसिम्प्टोमेटिक रहा.
सर उसके बाद वापस आया. तो आपने उसको 1 साल का ATG दिया, तो reactivation की क्यों होना चाहिए? सर खत्म होना चाहिए ATG. So this means after a year of tuberculosis, it was still inside the body. After 1 year of ATT, जो कि recommended नहीं है, 6 महीने की recommendation है. 1 साल देने के बाद भी patient को वापस symptom आ रहा है.
कोई ऐसे हम
I'm not saying it is MDR. I'm saying I would have counseled her for a peritoneal biopsy / diagnostic lab before starting. Peritoneal biopsy / diagnostic.
So I think MDR now we use very unusual. I've not seen in my life.
Extra
MDR
I've not seen that.
MDR होता है. We have not seen this scenario. But typically ये होते हैं sir. I don't think this scenario.
वैक्सीन आपको
So the children would gain a little bit of higher vaccine. Something that
Is it 1 year of treatment enough for the reactivation tuberculosis?
Right. So 1 year is enough for reactivation.
I'm not an expert in tuberculosis, sir. But the standard recommendation for tubercular ascites is 6 months of maybe
6 months.
6 months here. Recommendation 6 months here. 6 months. And you have to pay, right?
एक चीज पूछनी है कि जैसे
Tuberculosis earlier is
20 years back. 20 years back.
tubercular ascites है सर, तो उसमें हम पेरिटोनियल वैक्सीन रिकमेंड करें या मैंडेटरी होने
It is not
चाहिए?
mandatory. In India, it is not mandatory.
It's not.
So for tuberculosis, I'll only ask for a biopsy when malignancy is very high on my differential. So make this lady instead of 20-year-old, say a 45 or 50-year-old lady, and I'll be doing a biopsy at whatever cost it is.
So I think
That will become very, very difficult.
see on people meds. We not seen fever, so long fever, high-grade fever, unless it is secondary infection.
Fever भी होने के साथ
Second, if the patient has a sinus gone up, fever gone down, possibly there is evidence of tuberculosis. Clinically. Clinically. That is नहीं है, पेपर नहीं है. Definitely it should continue.
Just like tuberculosis.
अगर suppose ये हो रही होती, it should take in a different course. Right?
Different.
Result के natural side is again defilling of peritoneal fluid and everything, but now it is not in that case. So CA is a subject market definitely, but of course the serial market, CA is important in this particular. Yes, sir.
सर एक क्वेश्चन मेरा डॉक्टर पंकज चौधरी से था, तो जितने भी मैंने रिसेंटली ट्यूबरकुलोसिस के पेशेंट ट्रीट किए हैं सर, सबका वो एलएफटी हाई हो जाता है, एसजीपीटी एसजीओटी, तो क्या करना चाहिए?
ऐसा नहीं है.
मेरा जो प्राइवेट प्रैक्टिस का एक्सपीरियंस 1-2 साल का ही है.
1 से 5 गुना
इससे क्या मतलब है?
सर 3 to 5 times effective होता है. अगर 5 से ज्यादा बढ़ता है 3 to 45 times. Sometimes वो 3 बढ़ता है वो 8 to 45 times. It's not like we should continue to 3 to 5 times. उससे ऊपर ज्यादा नहीं बढ़ा.
Age is also important in KTT. So we should try to reintroduce the ATK after the first time drugs. After the possible biopsy should be done.
Obviously, issue is the issue है ना.
Because these cases where we diagnose the patient as tuberculosis turned out to be lymphoma.
Right. So अगर टेटोनिला में मिल जाता है, टेटोनिल मिल जाता है, वो तो टेटोनिल होती है. And in fact, MDR is about the more
Ethical bacteria can also be.
illegal infection. It is bacteria. I think बहुत ज्यादा हो गया था. I think this is the speaker. So
इसको बहुत बड़ा
when I talk to ये केस बहुत वर्कअप किया मैंने इसलिए जो है हमारा वो प्लेटफॉर्म है अनवर्क का वो सब ले आओ सब कर लेंगे. So I think that is वर्कअप और डिस्कशन जरूरी है. हमारे पास आप क्या करोगे? आते हैं केस the center है संतोष में वर्कअप हो गया. पेशेंट का ऐसे आपको वर्कअप भी होता है पूरी ऐसे सर आपके
बहुत अच्छा केस है, बहुत अच्छा करता हूँ.
और ये सब पेशेंट में इम्पोर्टेंट है हाउ टू गो बिकॉज़ आजकल मेडिकल लिटिगेशन में क्या हो गया so you have to take some action right and it's good that we have referred the patient क्योंकि जब पर है वो वैक्सीन आ रहा है so definitely we have referred to vaccine. So I think thanks and I think for our speaker for this presentation and other thing procedure was okay corporate our presentation was very nice. Other thanks and contribution for complete. Student and two Jacob करते वाले सर. डॉक्टर आप
थोड़ा सा बेटर हो जाएगा. This is the best. Thank you, sir.
So coming up with the next is So in my specialty, we have started the PNB SL, this super specialty also. So we have a seat in cardiology, information cardiology. For Gautam case, background of Gautam, okay. He's been there, he cannot pick up everything. He has a good, great knowledge and very good information cardiologist. So again, we are discussing that this abnormal case. dengue though, और सारे patient dengue के patient पास जाते हैं, पहले कुछ और नहीं करता उसमें. Right, so I also wanted to just limit a simple about this case, what has happened, and then Yorisha, the first aid cardiologist, will present this case. And to chair the session, we have honored to have Dr. Ajimita sir. Thank you, sir, for coming. And Dr. Makkar is always there. I told him the universal chairperson. कोई मिलता नहीं तो Dr. Makkar में जाता है. क्या भैया सेकंड आप कर्म में जाने वाला है. Right.
Good afternoon. So this case was very interesting because, he presented to us as a STEMI code. So whenever there's a ST elevation in an ECG in the ER, we activate a code, or rather the ER guy can also alert and overconfident with the ECG interpretation. And they activated the code. So this was a very young guy. And the lab was ready and we were all ready to jump in. Then we had a history that he had some fever and which was diagnosed as a dengue fever. So obviously, any sort of a febrile illness can, precipitate acute coronary syndromes also. We had that in mind, and subsequently, how the case unfolded, Dr. Isabel, very interesting.
Good afternoon, all. Presenting a case of atypical presentation of dengue fever. A 23-year-old male resident of East Delhi came to emergency of Max Hospital with chief complaints of fever since 10 days, shortness of breath since 2 days, and chest pain since 2 days. Patient was in his usual state of health when he started to complain of fever, sudden onset, intermittent in nature, associated with chills and rigors, but no diurnal variation. Patient went to outside hospital for these complaints where investigations were done and he was found to be dengue IgM positive. His platelet count at the time were 3,24,000 and he was sent home for conservative management at home. Following which fever subsided on the 7th day with the prescribed medicine. The 10th day, that is 2 days before he presented to our hospital, he started complaining of sudden onset chest pain and shortness of breath. Chest pain, which was retrosternal pain, sudden onset, gradually progressive, radiating to bilateral shoulders with worsening on lying down in supine position and on deep breathing and coughing, and relieved somewhat in sitting position. Associated with shortness of breath, sudden in onset, gradually progressive, orthopnea was present with no PND. No history of swelling in limbs, nausea, vomiting, sweating, syncope, palpitations, or any bleeding manifestations. Past history, no history of any similar complaints in the past, no history of hypertension, diabetes, CAD or asthma, and no risk factors for CAD were present. Personal history, he was vegetarian with normal appetite, normal sleep, and normal bowel bladder habits, non-alcoholic and non-smoker. Course during hospital stay was for above complaints, patient was brought to our hospital and on examination in the ER, patient was dyspneic, restless, conscious and oriented. He was afebrile with a pulse rate of 132 beats per minute, blood pressure 137/78 in right arm in supine position, and he was tachypneic with saturation 95% on O2 support. JBP was raised and bilateral crepitations were heard in bilateral lung fields. S1, S2 were heard but no murmurs, no pericardial rub. ECG was done, which was suggestive of normal sinus rhythm with ST elevations in V2, V1, V2, V3, that are the anterior leads, and also in the inferior slight elevation in the inferior leads, that is in 2-3 AVF.
Yeah, so if you take a pause, it lands up to anybody, any ER. The first would be the problem the road, distant road, other road, slope it up,
आपके सर क्या view is this when this patient comes to you? I think ST elevation is clear. Because we have to roll out the elevation by respective years. We have seen 20 years, 22 years. I think the patient should go for coronary angiogram. like in COVID, we have so many escalation, but angiography was normal.
Cardiac enzymes हुए थे डॉक्टर?
Sir, yes,
And
sir.
then will be raised, definitely.
तो ये तो सर अब कभी हम स्टेज पर पॉज करेंगे कि हम क्या करेंगे ये किसी की हमें आई हमारे पास तो ये हम we only held back because as sir said yes we expect that 23 we can have but we just wanted to hold back mainly because दो चीजें थी सर एक तो था कि उसका हिस्ट्री 2 दिन की थी तो we actually wanted some हम करना नहीं चाहते थे 23-year-old फीवर था तो हम करना नहीं चाहते थे एस्केलेशन तो हो ही सकता था तो वी टुक दैट फिगर की हाँ 2 दिन का पेन है वी सेड विल टेक सम टाइम क्योंकि हमारे यहाँ तो होता ना फिर वो ऊपर ही पहुंच जाता है और लैब में जाना ही पड़ता है तो हमने कहा रुक जाओ एक बार अभी कोड को हमने डीएक्टिवेट किया हमने कहा 2 दिन की हिस्ट्री है वी मेक इट day 2 एंड विल इवैल्यूएट अगेन
It actually came up 10 days. 10 days have already come.
फीवर था लेकिन पेन उसको 2 दिन का
Eight doses are asked.
एंड देन वी ऑब्वियसली फिर हमने नॉर्मली तो सर हमारे स्टेमी में ऑलवेज होना चाहिए बट इट इज सो सच फास्ट मूवमेंट वो इको भी हम नहीं कर पाते तो उसमें भी इट इज वी वांट द लोएस्ट डोर टू बलून टाइम
Which are the pain of my typical like retrospect.
no but pain the other part was
Sir.
then we evaluated this part इतना डिटेल में पहले नहीं लिया था but then we went to ask तो ये लेट के हो रहा है बैठ के ठीक हो रहा है
वैसे भी
Pericardial.
notice होती है पहले एक बार आता है फिर सेटल हो जाता है फिर दोबारा डेंगू में अरे अभी डायग्नोसिस नहीं
तो थोड़ा फिर हमें पेन भी लगने लगा कि अच्छा पेरिकार्डिटिस ना हो क्योंकि ये तो लंबा सांस लेने पे भी हो रहा है गड़बड़ बदलने में भी हो रहा है
Right hypochondrial pain था
हाँ थोड़ा पेरिकार्डिटिस
इसमें वो right hypochondrial pain था cholecystitis वाले को picture कर ले
नहीं ऐसा कुछ नहीं ऐसा
Sir, he had dyspnea.
वो प्रेपरेशन थी तो he was like apparently looking failure
Acute
तो मतलब
failure.
clinically तो he was failure तो ये सब failure के साथ था
One thing is one thing I just want to comment that because in pericarditis we have inconsequential control sheets especially on leads normally.
right
But you can see it is probably lever to before but retroceptor.
नहीं मतलब इसका अगर और इसको डीपली करो तो वैसे 2-3 एमए पे भी हल्का हल्का है
Slight
and there
elevation.
is no reciprocal
Reciprocal
changes actually क्योंकि reciprocal होने चाहिए उस हिसाब से inferior so there are no reciprocal that is a very a pointer in favor of pericarditis although इसमें PR depression नहीं है जो कि आप pericarditis में हम ढूंढते हैं
वही ना अगर पेरिकार्डाइटिस में कॉन्वेक्स कॉन्केविटी अपवर्ड्स हो जाती है
More suggestive or
और फर्स्ट टाइम मतलब ये था तो हम तो लैब रेडी थी ना
it is convexity, not concavity. You can see the
Sir, the
that was actually thought of
रेडियोलॉजिस्ट प्रेजेंट कर रहे हैं तो एमआई को नहीं
नहीं हम तो सिर्फ उसी हिसाब से कर रहे हैं कि कैसे हमने अप्रोच किया तो हमने एसीएल तो रखा पहले तो हमारा स्टेमी था दैट वाज हाउ तो लोड तो खैर हमारे जाने से पहले हो चुका था वो अप्रैल में मिल चुकी थी तो दिस वाज हाउ वी स्टार्टेड
The differential diagnosis for the case was acute coronary syndrome, viral myocarditis, pneumonitis with pericarditis, and pulmonary embolism. Differential diagnosis based on clinical. Our approach for the case was on day 1 when the patient was admitted, he was examined and started with supportive care. Echo was done, which was suggestive of global LV hypokinesia with EF 25 to 30% and moderate pericardial effusion. Investigations were done where NT-proBNP was 6,270, CKMB 62.1, TROPI was raised 10.4, CBC-RFT were normal, LFT was suggestive of transaminitis, and the CRP was raised, suggestive of some inflammatory process which was going on.
X-ray
X-ray was suggestive of cardiomegaly with fluid overload. Working diagnosis at the time was acute coronary syndrome and viral myocarditis. Immediately, he was stabilized with IV diuretics, NIV support, and aspirin. On day 2, patient symptomatically improved, dyspnea settled, tachycardia persisted. Bilateral basal minimal crepitations were heard on auscultation. On ECG, ST elevations settled but seen only in single chest lead. Echo was done, which was suggestive of pericardial effusion, which had decreased, and EF 25%. Now the working diagnosis was viral perimyocarditis with ACS, query ACS. So this is ECG on day 2, where we can see ST elevation only in lead V2.
One or two.
There is some.
There is a
Wait, one V3 also, sir. V3, V4 with no reciprocal changes. Day 3, patient symptomatically better, dyspnea settled, and he was maintaining saturation on room air. The resting myocardial perfusion scan was done to rule out ACS or CAD, and it showed that there was viable myocardium. And he was started on ACE inhibitors, and Ramipril was started with the working diagnosis of viral myocarditis / perimyocarditis leading to systolic dysfunction. On day 4, patient symptomatically improved. ECG was suggestive of normal sinus rhythm with ST elevations that had settled. Review 2D echo was done and global LV hypokinesia with mild pericardial effusion. Mild MR and EF was improved to 40 to 45%. Cardiac MRI was done, which showed mild mid myocardial early and late gadolinium enhancement in anterior, anteroseptal, and inferoseptal segments, which was suggestive of myocarditis. And patient was started on tablet colchicine. ECG on day 4, the ST elevations have settled and it is almost normal sinus rhythm. Day 5, patient condition improved. ECG was normal sinus rhythm and repeat 2D echo was done with minimal pericardial effusion and EF 40 to 45%. Patient was discharged in stable condition. This is the ECG on the day of discharge, which is completely normal, settled to normal. Did not do an angio.
So our reason for presenting it, we had to hold ourselves back to chance दिया हमने नहीं करके और वो हमारे को टैकीकार्डिया था तो day 2 पे there were some indicators we believed were not in favor of ACL and both in patients we've seen some patients. Sorry. Yeah, so it was very, very global and it was like non-pericardial effusion. So we could not, that was one pointer that, large. हाँ, echo तो वो ECG भाई हमने active port तो activate हो गया ना सर तो सिर्फ हमने hold because of the age and because we thought कि fever है तो थोड़ा दिमाग में
IgM positive, sir.
So yeah, so he was a
acute dengue में कर सकते angiography और
normal जैसे
the bleeding tendency तो
नहीं वो तो platelets कम हाँ मतलब वो any inflammatory condition you can have. So but he was very lucky chap. Normally इतना course stable और इतना healthy recovery नहीं होती. We've had patients in the past of maybe not dengue, maybe viral illnesses. Who presented like this. Yeah, it's like a yeah, dengue, myo. Which was so it was proven on MRI. So MRI we proved that there was mid myocardial other enhancement that is typical of myocarditis, not of ischemia.
One question from my side. So now
Classical dengue.
cardiac MRI is not available, not everywhere, not some centers. So what is your current indication that where the patient will refer to the cardiac MRI? Cardiac MRI. What are the indications?
Indication of doing cardiac. No, so for wherever you are suspecting myocarditis, MRI is the gold standard for diagnosing, and it can help to differentiate from ischemic etiology. See in MRI on T1 images, or T1 weighted जो होते हैं उसकी images, उसमें there you can make out myocardial edema very nicely, and in T2, like in this case where there was mid myocardial enhancement, in ischemia. It will be from the in the endocardial side. Isme it is from the epicardial side. So there are, MRI, radiologists will tell you, myocarditis lag raha hai. Colchicine anti-inflammatory. So we also started later कि क्या उसके indications आ गई हैं. But now, obviously for pericarditis sake, that is a class 1 indication. And not for myocarditis so much, but for pericarditis.
COVID के third day में भी काफी कुछ recommendation from knowledge.
Dr. Gaurav,
what was the conversation with the relatives on the day?
I think that is also he was already counseled कि हाँ STEMI है तो इसको एक बार तो एंजॉय करके देखते हैं क्या हो रहा है.
What was their reaction? Did they really believe?
No, I normally वो नीचे काउंसलिंग हो चुकी होती है हम तो ऊपर पहुंच गए तो I don't know what was the reaction, but yeah, later we had to tell them कि अभी नहीं कर रहे हैं. So, but yeah, so there are young patients who come with and नहीं family support. ऐसा कोई there was no family. Most of them, frankly speaking, those who land up like this, Mittal would agree, would be smokers or at this age especially, or very strong family history. Those are the two mostly subsets जो हमने देखे हैं. वो dyslipidemia की तो बारी नहीं आती अभी. हाँ लिपिड वो सब तो फिर बाद में तो ACS था ही there was no reason. लेकिन I think वो लिपिड चला ही जाता है हमारा फर्स्ट सेट में.
Any possibility autoimmune chronic geography?
The way he responded, we didn't even delve into it. Acute migraine. So it was very, very acute, and there was no prior.
But I said this, you were very bold and not compared to the.
Not.
He should be following
हाँ वो मैंने भी आया था बिल्कुल normal ही. Yeah, so that's a very good point, Doctor. जैसे मित्तल ने कहा कि such patients because वो जो late gadolinium में enhancement है, that indicates कि extracellular space में वो चला गया है tracer. So that indicates that the cellular damage is there. So such patients should be on protective medication for 3 to 6 months, even if their LV has recovered. So that is a general statement also for people who develop, say, all other sort of, reversible cardiomyopathies. ये जो हमारी stress हो जाती हैं, या ताकत सुबह हो गई, stress ये sepsis induced हो गई, all those patients, many of them recover. Still, they should be continued for 3 to 6 months because such patients can develop, scar, the extracellular space. No, not anti-inflammatory. They should be on beta blockers and जो general heart failure therapy लोग देते हैं, ACE inhibitors, beta blockers, just to prevent a load, LV load नहीं.
What about colchicine? How long should be the colchicine?
3 to 6 months.
When we were holding the CAG, should we take the legally we should take the consent.
Or not doing the same.
We are holding it.
वो तो legal हो ही गया.
They are not refusing.
That is a decision.
ले ली ना सर, पेन पेपर पे ले ली.
हमने कहा चलो आप
These patients survive and suppose ये day 1 पे arrhythmia होके निकल जाती या निकल जाता तो फिर कितनी legality रहती not doing the angiography.
तो मैं mention कर रहे हैं very good not doing
Patient सही हो जाए.
लेकिन कोई हम नहीं, हम कुछ ना कुछ तो निकालते अपने को सेव करने के लिए. We would have obviously created a mahal to do that because we would, so there would be pointers. We can always contest. मैं contest करना शुरू करें, I can contest.
Final diagnosis of
Legal problem is very
वो उसका autopsy करा
The final diagnosis of our case was perimyocarditis secondary to dengue fever with LV dysfunction, where EF in the beginning was 25% and it improved gradually to 45% on discharge. Patient was managed conservatively with antiplatelet, that is aspirin, diuretics, ACE inhibitors, and colchicine. These are MI mimics. Basically, the ST elevation can mimic MI in these cases, which include left ventricular aneurysm, myopericarditis, as in our case, RBBB, hyperkalemia, the sinoventricular rhythm of hyperkalemia, benign early repolarization, Osborne J waves, right ventricular paced rhythm, LBBB, that is left bundle branch block, hypertrophic cardiomyopathy, premature ventricular contractions, and left ventricular hypertrophy patterns. These all can, the ST elevations, the ST elevation picture of these conditions can sometimes mimic MI. Discussion. Dengue is transmitted by the bite of female Aedes aegypti mosquito. Dengue may present as a wide spectrum of clinical presentations ranging from asymptomatic infection to severe fatal symptoms. WHO classification of dengue into following categories, that is dengue without warning signs.
Patient can go to the cardiac emergency now.
Sorry. Dengue fever can have various cardiac complications such as heart failure, cardiogenic shock, arrhythmias, myopericarditis, pericardial effusion, myocarditis, cardiomyopathy, or even acute coronary syndrome like picture as seen in our case, which can have ST elevation, raised troponins but normal coronaries. Rhythm disturbances such as atrial fibrillation, ventricular tachyarrhythmias, ventricular ectopic beats, bundle branch blocks, sinus node dysfunction, first and second degree AV blocks, and rarely complete AV block have also been seen in studies. Non-specific ECG changes such as STT changes and abnormal Q waves can also occur in myocarditis. There can be pulmonary edema or cardiogenic shock due to severe myocardial cell damage and with left ventricular failure. The increased production of cytokines causes rise in vascular permeability and abnormal leakage of plasma leading to pericardial effusion. Pericardial effusion was also seen in our case, which gradually resolved as the patient stabilized. Treatment usually includes supportive therapy as myocarditis and conduction issues are usually reversible. Follow-up after recovery after 4 to 6 weeks. This case highlights an unusual and clinically significant manifestation of dengue, that is perimyocarditis mimicking acute coronary syndrome. It underlies the importance of maintaining a high index of suspicion for cardiac involvement in dengue, especially when patients present with chest pain or dyspnea. ECG in dengue patients can help warn early. In the era of increasing dengue prevalence, recognizing such expanded dengue syndrome manifestations can prevent unnecessary invasive procedures, guide appropriate management, and improve outcomes. Thank you.
फाइनल वाले से एक क्वेश्चन है मेरा, ये बताइए मैम, डेंगू डेंजरस कब होता है, फेज 1 में या फेज 2 में, when it is more dangerous?
So dengue with
Dengue.
warning signs is very dangerous, sir.
When it is more dangerous, in the initial phases or in the second phase?
In the second phase, sir.
हमको बोलने नहीं दिया।
ये पहले फर्स्ट केस था, you like to know that just for a while, I just before announce this sitting and let me know the EDP campaign because campaign चला रहा है, उसको दे देते हैं award. Video campaign award is this month goes to Varun Luthra, yes sir. And don't dare to louder. Don't dare.
अरे ये तो आपको बताना चाहिए।
मुझे ध्यान नहीं आ रहा जी।
So, Dr. Pankaj discussed with you recently, I don't know how many EDP group done, there was an end of study of a major trial, Pelacarsen. We were a part of that. We had a significant number of patients enrolled in the study. So, वहाँ पर Dr. Himanshu, my associate, had traveled and we were felicitated there because India and we enrolled a lot of patients.